I'm a physician assistant, but I also have additional training, and I'm a nationally certified menopausal practitioner, as well as an ASECT certified sexual health practitioner. First, I started getting my certification in menopause because I felt like there was a lot of things that we misunderstood about that transition. And one of those is libido, right? And it fits nicely into mental health as well, because with anxiety, depression, ADHD, I feel like there are sexual health complaints that go along not only with the mental health processes themselves, but also with the treatments. And so it's tricky because sexual health medicine is not a specialty in the United States. So it's hard to find somebody who has the additional training to know how to navigate some of those concerns. I think everything just sort of came together. So I I started out in family medicine, and then I transitioned over to OBGYN. And while I was an OBGYN, I found that we did a fairly good job of taking care of moms while they were pregnant, delivering. But once women got to the menopausal arena, there wasn't that specialty kind of care, right? And there's also a lot of misinformation surrounding the data about treatment options. And so women would often go, hey, I just don't feel quite like myself. That's really the most common complaint of menopause, as opposed to hot flashes. It's just, I just don't feel quite like myself. What are my options? And we find that in especially the primary care settings, when you come in with that complaint, only about 15% of women actually leave with a discussion or options surrounding hormone replacement therapy. And we're misdiagnosing this, I don't quite feel like myself, not as possibly issues with the menopausal transition, but instead labeling it as depression or anxiety when it doesn't fit that criteria.
So I've practiced in Michigan for a few years, and I also teach at Grand Valley, and I had a student who was a women's health nurse practitioner, came back to become a psych NP as well, and wanted to really focus on that intersection of perinatal mental health. And I was looking for someone who could be her preceptor, like her internship manager, and that person did not exist anywhere that I could find in West Michigan. So that was troubling. And I had been seeing, more of a generalist patient population for mental health concerns, but I have two small children. I have a lot of friends of childbearing age. I do some work with Moms Bloom, which does peer support for moms. So it was definitely on my radar that there's a need for that mental health management, either with planned pregnancies, unplanned pregnancies, the medication side, therapy. There's so much more that we can be doing to support birthing people. So I decided to do that specialization and really feel confident knowing what I was doing, working with those patients, and focus on that specialty. I think it's sort of like a process of elimination when people get to my doorstep, because like I said, we're not really addressing the hormone side of it. There's a lot of overlap in the symptom presentation. And sometimes, if you look up the actual evidence-based research for treating things, we were just talking about PMDD, you want to treat the hormone side of it, but there also is kind of a mental health side of it. So oftentimes we'll treat it with hormone replacement or modification, and then also something like an antidepressant or anxiety medication. So I don't think it's ever either or. It's always kind of both. So maybe it's more about the kind of stage of life and the circumstances surrounding the patient versus the symptoms. I don't know. You chime in, Elizabeth. I don't know if I'm making any sense.
No, I think that question was a really hard question for your specialty. I don't know if it was phrased as well as it might have been for menopause, right? So for menopause, I think that question makes a lot of sense, right? So how do you know when I'm going through menopause and I just don't feel like myself? When is it depression, or when is it just part of that menopausal brain fog, low mood, what's going on, right? So I think that gets a little bit convoluted. Women who've had previous depression have a 60% chance of reoccurrence during the perimenopausal time span, right? So if you've had anxiety depressive episodes in the past, you're more likely to have those happen again during that perimenopausal time span.
Yes, I think in terms of like if I'm working with a pregnant person, I'm gonna let their OB-GYN or their midwife do some of the more like physical health pregnancy side of things and testing. And of course, that's something we pay attention to as well. But I agree. I think that's the benefit of getting to see someone in more of the specialty space, is that we have these longer appointments where we can really get to know you. It's going to look different than if you show up at, if you have 15 minutes with your primary care provider and they're not able to get the full context.
One thing I hear all the time from people, they come in and they're like, oh, well, my primary care, like, it didn't listen. And I'm like, well, hold on. Like, I love my little primary care people, but they only have like 10 minutes. And so they can't walk you through your risks and benefits. They just don't have the capacity to do it sometimes within their time constraints. And so I do think that we can complement each other very nicely. And I love my specialties that I work with, and then my other primary care people as well. It's just, we all do the best that we can to help our patients, right?